Yes? Right, try again. Good evening, everyone. I'm very pleased to see you here on this rather chilly evening, and I hope it will be a very interesting meeting. So welcome to you all, and welcome to the people watching from home. I know that our podcasts are very popular, and I hope it will continue that way because it's a very interesting meeting covering a lot of interesting subjects. We have at least one new person here tonight, which is Sarah. I'm very pleased to see you here, Sarah, as Director of Place for York, and I know you've got a slot on the agenda. And we'll welcome John from the Independent Care Group and David as the other sub from TÜV. I think everybody else hopefully will know everybody else. First of all, I need to just say that Lisa Winwood has already been up here to see me to say that she's involved in another meeting, and I have a funny feeling it's budget, so she certainly can't leave it, but she will come up here when she can, which is good to know. Any particular declarations of interest that anyone would like to declare? No, that's fine, thank you. Minutes of the last meeting I have in front of me. I've read them very carefully. Thank you to Councillor Waller for chairing that meeting in my absence. I had a very interesting experience of the hospital service from the inside instead of from the outside. I'm pleased to say they gave me excellent care. So I'll sign these as a correct record.
Chair, just in terms of matters arising, if I could just seek clarification, I have through Tracy, in terms of on page 8, the updated report from Healthwatch, I understand will come to the next meeting. I just wanted that report.
Just to say, I have checked with Tracy. There are several outstanding matters. She wasn't very well when I wasn't very well, and she's going to pick all those up and bring them, as Councillor Wallace says, to the next meeting. So thank you. We have one public participant. Right, thank you. Flick Williams should be joining us. If you can bring her in and she can have her chance to talk to us.
Good afternoon. Can I begin?
Please.
The Healthwatch team is to be commended for their report on the cost of living emergency. Whilst there is zero comfort to be taken from its pages, this work has enabled those experiencing the most difficult circumstances imaginable the opportunity to have a voice, to share their stories and their fears when many feel that no one is listening. I fear that those experiencing the very worst circumstances, those whom were barely scraping by before, are likely to be underrepresented in this survey. Those who are drowning, not waving, are much less likely to be completing surveys. Whilst there are no easy answers to this truly unprecedented crisis facing an ever-growing number, my purpose in speaking here today is to provide board members with some additional information as it relates to disabled people specifically, of which they may be unaware. Just yesterday, news that the legacy benefits appeal has failed. During the height of the pandemic, claimants on universal credit received a £20 uplift, which was denied those on legacy benefits, predominantly those disabled people on employment and support allowance. Somewhat incredibly, the judges in the Court of Appeal have found for the DWP, arguing that the uplift was to prevent welfare dependence rather than to relieve hardship. Similarly, assumptions are made by many that government has singled out disabled people for extra financial support with energy costs, but not all. Those on contributions-based ESA are denied the extra £650 payment, despite their weekly support being only a few pounds more than those on income-based ESA. A disabled woman I know who has a young child told me the day she learned she would not get the £650 was the day she felt unable to carry on. The fuel poverty that a growing number are facing is dire for those disabled people whose energy usage is high owing to their equipment needs. Much disability equipment is costly to charge, such as wheelchairs and hoists, and some must run continuously. Add to that the costs of heating, where many have conditions that leave them unable to regulate their own body temperatures. The response from energy companies making billions in excess profits is to counsel disabled people with, can you not turn your oxygen concentrator off for parts of the day? Most alarming is that as people fall deeper and deeper into energy debt, suppliers are doing two things. For those with smart meters, they are putting households onto prepayment with the flick of a remote switch. For those without, magistrate courts are approving thousands of warrants per month to allow suppliers to forcibly enter homes to install prepayment meters. Fuel Poverty Action argue prepayment is disconnection by the back door. And should we reach a position of supply shortages and power cuts, disabled people on the priority services register have been written to and told they must make their own arrangements. Tragically, avoidable deaths seem inevitable. Thank you.
Thank you, Flick. That's very helpful for our discussions, but I just want to say to those listening and watching that there is help that can be obtained through the council. And if you have any concerns, the Citizens Advice York will try and help. We have a financial advisory board which has a fund which can help. And your local area coordinator or your social prescriber, local people, are always able to help. And anybody who thinks that they know somebody that needs that help, please try and find out where that help can be obtained. Because certainly when I read the report, there were some people I thought I could refer them to X, Y, or Z had I been in that situation personally. So thank you very much indeed for coming to talk to us. And now we go on to the Healthwatch report, page 15. And Sian is going to talk to us about it.
Thank you, Chair. Yes, I must say, in my time working for Healthwatch York, this is the first time we felt the need to put a content warning in one of our reports. It does not make easy reading. It is a difficult report to have prepared and to present. Within it, I totally take Flick's point. We may not have heard from those people who are, sorry about my voice as well. I've got a bit of a cold that isn't helping. But we are concerned about whether or not we are hearing from the people who are most affected by this. And it links at the moment with work that my colleague Roger is doing alongside colleagues at City of York Council, looking at the council tax benefit system and what happens if you get into arrears. And he is currently doing phone conversations with individuals identified who have been part of that process. And I think the thing that struck him, we originally, is this work that Healthwatch should be involved in? And he said what struck him was that every single person he has spoken to so far has an existing long-term physical or mental health condition. These are the people who are living in poverty in our city. The connections between being a disabled person and living in poverty are absolutely written clear. So I don't think it's any surprise that within our report, one of the findings was that those people with existing physical or mental health conditions are disproportionately affected by this, and it is exacerbating those health conditions. I know in other areas, the NHS has piloted schemes where they pay for people's energy bills, where they've identified they have a health condition that will be made worse by living in a cold house. I think it is truly remarkable that we are having these conversations, and truly awful that so many people in our community are deeply affected by this. one of the conversations that my colleague had with somebody about the council tax benefits system, they indicated they had tried, as is being advised, to improve their circumstances by taking on some overtime. And unfortunately, they didn't realise that would impact on their council tax benefits. And now they are in a position where they may well be taken to court if the pilot project that City of York Council are currently running isn't able to help her. That's the situation. That's the world we're living in. So I don't think I need to say any more. I think this report speaks for itself. I hope you've all read it. We will be repeating the survey and we will be doing everything we can to get more people to fill this in. I would also say what doesn't come out of this report is the impact on those people working with people in poverty. And every day I am impressed by my colleagues at CVS, whether in the social prescribing team or in other work areas, who are asking us, do you have any jumpers that you were going to take to the charity shop? I'm working with a family, they could really use them. The other day, I just bought something for this person because I knew they needed it. I'm very aware that my colleagues in the voluntary sector are not hugely well paid. They don't have a huge amount of money, but they are digging into their own pockets to make sure people are not going without. And I think it's a bizarre world we live in at the moment. I think that's all I want to say. Thank you.
Thank you, Sian. Before I ask for any questions, I'd just like to ask Sarah if this will come up with York Place and the ICP, because I think, as Sian says, it relates both to physical and mental health. Would you know if it's going to be discussed?
Thank you, Chair, and thank you, Sian. So I think the answer to that is unequivocally yes. I think it already has been. Certainly, it did come up at the partnership meeting on this week. We had a York Health and Care partnership meeting on Monday with partners across health and care, and we did discuss this in terms of the impact both that the voluntary sector is seeing going out to support people, and also from Sian herself. I think as well as within York, there has been quite an undertaking in terms of additional survey work across York in terms of the community that we're serving from a health perspective, and also a survey of wider staff, members of staff working in health, and the impact on staff as well in terms of the cost of living crisis. So in terms of the conversation with the partnerships and the work that the partnership is doing, I think there is already some action in terms of making sure that we are communicating with our providers, our service providers on the ground, in terms of our social prescribers, our primary care, DPD practitioners, etc., to ensure that we know where the most vulnerable people are. And I think we'll be coming to the ICP strategy, the wider Humber and North Yorkshire strategy later, but I see a lot of parallels there, but certainly feels that we are taking this very seriously within York. Thank you.
Good. Thank you, Sarah. I'm pleased to hear that. I just need to say to you, although I could actually hear everything you said, if all speakers would speak straight to the microphone and resist the temptation to look at me, because I'm using the hearing loop. And if you turn away, I can't hear you quite so well. Thank you. Any questions now for, yes, Alison?
It's not a question, it's just a comment.
Right.
Two comments, actually. So firstly, on the our Poverty Truth Commission that I've talked about before. So we're identifying issues which will be shared in our launch in March. But one of the things I mentioned at the Health and Care Partnership this week was that all the commissioners that we are working with have underlying health conditions, which just adds, to the fact that it is people living in poverty who are really suffering the most. But I just wanted to mention also, just to add to this, about the voluntary sector organisations that we work with as well. So they are really going to be struggling going forward. So most of us have contracts which do not have a cost of living increase full stop. And if they do, it's not going to be more than 3% unless you're extremely lucky. But what I'm particularly concerned about are the energy costs. So at York CVS, for example, our electricity bill has gone up from 11,000 to 43,000 just for electricity, so for the lights and the kettle and the computers. And we will have to pay for that from our reserves. And we are lucky that we have reserves, but I'm concerned that during COVID, many charities used a lot of their reserves. So I'm not sure what's going to happen. So I'm doing a survey next week to find out what's going to happen, because obviously we don't want to be losing charities because of the energy costs. But the government scheme that was announced, I think this week or last week, will give us £1,300 towards that £43,000 bill. It's very helpful. So I'll just put that up. So I can report back when we have that response to see what's happening with the sector. Just to share the joy and the gloom with you.
Thank you, Alison. We won't go into this very deeply, but if there are some more comments, and I think Councillor Waller and Councillor Looker would like to make some comments, we have to remember we have to receive this and it goes on to a committee. Councillor Waller.
I think Councillor Looker was before me.
Your microphone on, use it.
Right. Thank you, Chair. Yes, I did read this report with extreme trepidation, really. I'm aware within my own ward the impacts that this has had on a wide range of people, many of whom have come to me just to find out what help there is available, and it's signposting people and in some respects persuading people that get what you're entitled to, that there should be no shame in doing this. But I think it's important to consider the impact of the slowness of the reduction in fuel prices working their way through the system. It's very frustrating on social media to see that sometimes gas prices are the same as they were before, but that is not helping people now, and it's already baked into a wide range of different fuels that is affecting people, and people are making choices that really is not healthy for them to be making. So I think it's important that we put pressure on government to make sure that there is a sharing of the benefits. One of the consequences of no longer being part of the EU is that we can't share in their efforts to windfall tax the companies that have made enormous profits, and that our food prices are significantly higher than if we were in the single market, and it's particularly affecting low-income people. I think the point that you raise about people who trying to help their situation, they trigger losses of benefits, and that was already a concern in the system, that people who qualified for free school meals were in one situation. There were people still struggling, but because they were in a particular universal credit situation, they were disqualified from a whole raft of experience of support. And the same in your report mentions nursery prices, and there's a tension there between nurses struggling to survive. There hasn't really been the support for fuel in the education sector that there has been in other areas, and therefore it's putting pressure on people who need nurseries in order to go out to work. And I think that's something that I know with Martin as director, we are looking at how early years can be guided through this very difficult time in order that they are at the other side. But you're right, many organisations have used up their reserves during COVID, and this is a severe hit. Thank you.
Thank you. Councillor Looker.
Yes, I can't say I read this report and detected many rays of sunshine at all. I can't actually think, and I've been around a long time, I can't actually think of a time when I have been so ashamed to be British. I think we are living in a most appalling society that seems to have lost any humanity. I used to be very proud of the social benefit system. It wasn't perfect, God, it wasn't perfect, but it did seem to respond reasonably well to people's needs. And you could advise people that it was a safety net. It was a safety net. Now it seems to be it's barely a safety net, and frequently has such enormous holes in it. Councillor Waller's mentioned the free school meals issue, which has been actually around for ages, but is flagging up even worse now. My practical suggestion that I want to make to this board, arising out of this report, is are we collecting the data about the adverse results? Because I think we're going to see deaths. I mean, newborn babies are a particular issue. There's real worry that if people are trying to save on fuel, can't afford to heat their homes, very new babies, equally as much as the poorly disabled and the very elderly will suffer. And children, babies' abilities to self-regulate their temperature isn't really very developed. And I mean, I know it's small numbers, but I really do think we should be looking to collect some statistics on some of this, because I think that impact of deaths, and I really do think deaths will occur because of this. I also think children's development will be severely disempowered. I think there's poor diet, being cold doesn't help you develop all sorts of opportunities, which you will miss once you've stopped being 5, 6 or 7. You can't recapture some of those early goals. And I mean, we're already seeing children going through the education system who are suffering the impacts from the COVID lockdowns, which stopped them getting some of the social benefits that they should have got at the ages of 2.5 or 4. And I think we're going to see some of that again. So I really do hope that my colleagues around this table are going to be collecting data, however small. I think it will be significant, and I think we should be aware of it. And I think we should be able to report back to bigger and higher and more authoritative people to say what some of the real actual impacts are. So yes, I mean, it was needed to be done, but I can't see any magic wands floating around this one.
Before I bring in the last 2 speakers, which is Jamela and then Denise, just to say that we've just been discussing this in the ICP immediately before this meeting. And one of the problems is data lag, that you don't get the data for here and now, you get it a bit later. And of course, what you actually want is to have the figures over a period of time. So you can see if there are excess deaths, as they're called, in whatever age group, because it's a very important indicator of what's going on. Jamela.
Thank you. I don't know if Sharon wants to comment about data before me, if that's okay.
Yes.
Yeah, thank you, Jamela. I mean, it's just to say that we do have some real-time data. So we do in public health receive the death data from our registrars. We receive that on a weekly basis. So it does act as an early warning system. We set that up during COVID and reintroduced it as a result of the concerns really around cost of living and everything else that's going around at the moment. Also, the ONS data that we get is more up to date than it used to be. And through the Population Health Hub that Peter heads up, we also have the ability to bring our data experts together to be able to gather not just hard data, but soft intelligence, which is also really important to understand what's going on at the moment. So, you know, it's not as though we're going to have to wait 2-3 years for data to go up to government and be sifted and sorted and then come down again. While I've got the microphone, Chair, I just also wanted to thank Healthwatch for the report, but also to share some of the concerns that I have, particularly around young children. You know, there's a lot of intelligence coming through from our health visiting service in particular about some of the challenges that parents with newborn babies and young infants are experiencing
around cost of living. Sadly, we've had at least 2 examples of small infants being admitted to hospital with hypothermia. And we also have significant concerns at the moment about families who've chosen to not breastfeed their infants, but to use infant formula, that they can't afford to buy the infant formula. And because of the challenges with the Healthy Start scheme, the eligibility criteria around the Healthy Start scheme, we are seeing families under enormous pressure, and that is certainly something that we're looking at the moment. People may not be aware that food banks will not provide infant formula. It's to do with their policies and the way that they work. So we want to look at the pathway of support that we have for the infant formula as well at the moment, to make sure that families aren't losing out. But, you know, just reflect what everybody says. You know, there are significant practical implications of that go even further than the report that we've got in front of us.
Yes, thank you, Sharon. I was very concerned to read that some people are diluting infant formula to make it go further. That's a very, very risky thing to do. And anybody who's listening, who's thinking of it or knows somebody who might, please advise them not to.
Thank you, Chair. Yeah, I just wanted to start off and say thank you, Healthwatch, for the report. It's really comprehensive and shows what's going on across York as we are today. Just looking at my data for the last 2 weeks, we've almost doubled the amount of people who have accessed our information advice straight into adult social care. And something with the data, we don't have the here and now data as we would like it, Councillor Luca, but the Population Hub has actually given us data around people with long-term conditions. And what that has enabled us to do is do early reviews on those people with long-term conditions who are at home. So we've expedited some of those reviews and put added support around them, especially people with disability. We have lots of working age people with disabilities are finding it difficult really to cope at home on fixed incomes, as it were. So those are the ones that we are supporting. I think we've done 750 reviews since November till now on those particular individuals who have a number of health conditions who may require additional support. I think the second point I wanted to come on was Alison's point. It'd be really good to see that survey, Alison, around the voluntary and community sector, because we are really committed to supporting the voluntary community sector, because they support lots of our vulnerable people, some of them that actually even don't come into either health or social care, and we want to make sure that we are supporting the voluntary sector in the right way. Thank you.
Our last speaker on this agenda item is Councillor Craghill.
Thank you, Chair. Just a few comments. I just wanted to say, first of all, that it is really useful to have this report and this information. I think it complements other information we've been gathering, but it gives you that voice, that direct voice of experience. So that's really useful to have. Just picking up on a few things, I think if you're looking at, you know, the big answers that need to come from government, which you can't actually make happen here apart from lobbying, you know, I think we should impose a windfall tax on the energy companies anyway. I think in response to the comment about benefit sanctions and people trying to take action and then being penalised by getting more work, we need a basic income scheme, and we should be lobbying for that, so that sanctions don't actually stop people getting more money when they can. And we need to insulate, we need a massive programme of insulation. So that's my sort of, you know, government level dreaming. What we can do locally, I think we are doing an awful lot. And I think some of the things that come out, you know, specific examples, although a lot of it isn't surprising to anyone here, there are a few things that sort of come out and we could really try to pick up more. Obviously, obvious impacts on mental health, but also the thing about trying to reach everybody with that information that there is help available, and keeping on building on that networking and building up contacts. And I thought in respect of the health structures, just making sure that's really joined up with all the work we're doing on communities in the council. So, you know, the local area coordinators and the communities team, ward-based working, so that all those sources of support for people locally are known to everybody, and they can be passed on to people who need it. And we are trying to support people with energy advice. I know we're trying to put more money into that area through the UK Shared Prosperity Fund. So organisations like York Energy Advice and others can actually provide more advice and help on how people can make their homes warmer for less money. And just something I wanted to add, particularly with a health service perspective, was that the advice that's provided through GP surgeries has been a really positive initiative and has reached a lot of people. It's a really small amount of money in a way that's been really effective, and we keep on sort of casting around to fund it every year. And I think it would be really useful if this group was able to think about how we could make sure we can keep on funding that and maybe expand it. That would be a really useful thing.
Thank you, Denise. I think everybody who has anything to do with the voluntary and community sector knows that small amounts of money can make a tremendous difference. So we'll receive the report, Sian. I know you have to leave us, but thank you very much for presenting it to us. And we'll wait to hear when you have the next one. And you're bringing that to us, will you?
Yes, thank you, Chair. We will be rerunning the survey, probably early February, mid-February, very similar, but with a couple of extra questions, and we will bring the findings of that back as soon as we can. So thank you, everyone.
Yeah, thank you very much indeed. Now we go on to agenda item 5. 6?
Yeah, we're doing
Oh, 6 first, right, okay.
6 first.
Which is on page 55. And it's York Health and Care Partnership. Now I noticed that Peter's there. I thought Sarah was presenting this. Is it one
She is
or
chair.
other?
I came for item 5, so I will turn over.
Oh, I see. Yes,
Confused
like
me
me,
with
you
the
thought
order.
5 came after 4. Right, so Sarah, it's you. Agenda item 6.
Thank you, Chair. You're just trying to trick us. It's my first meeting and getting tricked by the order of the agenda. I was getting confused then as well, thinking I've got to present on the framework for delivery of performance management of the Health and Wellbeing Board strategy. So I think I'm probably more comfortable, slightly more comfortable with the York Health and Care Partnership report. So hopefully everyone's on the right page in the pack, just given the numbers are jumbled around. And just to say as well, first of all, just thank you for having me, really. I think tomorrow is my first month in Perth, so that's my month anniversary, with Christmas and New Year in the middle, and working very hard with my colleagues across the system to support the system pressures that we've been under during that time. So I certainly feel like my feet haven't touched the ground. However, I have spent as much of that time as possible meeting many of my provider partner colleagues, my council colleagues, and of course my colleagues in the wider NHS system as well, because I see that very much as being what the NHS place director role is all about, that convener role, bringing partners together around the citizens, the population that we all serve. So thank you for welcoming me, and the report that you have, which is in the pack, is very straightforward, I think. So I'll assume it's been read, but I just thought I'd pull out a few points if that suits everybody. And also, Jamila, I think we're down as a double act as well. So I welcome and invite you to comment if there's anything that you want to add or observe. And then there's a number of fellow members around the table. So invite my fellow members to comment as well, if that's okay, Chair. All right. So I think this item is a standing report. And if you move to page 3, that essentially just outlines what we covered at the last meeting, which was actually my first day in the job, which was the 19th of December. And just gives you a bit of a summary. I mean, just before I do that, and what is the partnership all about? The York Health and Care Partnership for me is about knitting together the partners who are responsible for delivering health and care to the city of York, and then how we knit that partnership to the wider system, including the Health and Wellbeing Board, how I knit that to the NHS functions of the new commissioner, which is across Humber and North Yorkshire, and to the wider integrated care partnership strategy that we'll come on to. The last meeting, you'll see that we talked about the system pressures that our system is facing in terms of the rising demand that we're seeing, and the industrial action that we've been seeing, and the planning that has been going on, and the pulling together has felt very much, I think, like what we saw during COVID, and the response that the hospital, social care, primary care, the voluntary sector, and many others that I've probably neglected to mention, really pulling together when it matters to deliver the very best we can in unprecedented circumstances. So the board discussed that at some length in December. That's a standing item where it's not just about talking about the problems that we're facing, but how we can help each other. And I think that's going to be a theme of the board in terms of what could we solve together in terms of these unprecedented challenges that we're facing. Also discussed at the meeting was the set of strategic actions that are in the appendix that you will see there. In terms of the partnership has agreed a number of priorities that it is going to focus on. I think probably I have a personal view around those as well, in terms of I want to get my head around them, really understand what those strategic actions and priorities are. And I say that really in the context of the Health and Wellbeing Board strategy. So are we as a partnership absolutely geared up to deliver the strategic ambitions for York as set out in the Health and Wellbeing Board strategy? So I think that's a question that I really want to test out with those strategic actions, to make sure that we are absolutely focused on the right things, and not just doing, bells and whistles, but in the context of the previous item, are we getting the basics right? Are we serving our most vulnerable? So, I think that's probably something that I will be looking at over the coming weeks. The prospectus, I think we'll probably maybe talk about that partly in the next item as well, but for me, there is a relationship between the partnership committee that I'm responsible for, the Health and Wellbeing Board strategy, and then the strategy of Humber and North Yorkshire Integrated Care Board. In many ways, I see the prospectus as the way to tie all of that together, because health is so complex, the system is so complex, and looking at integration, that multiplies the number of partners involved, quite rightly, but it becomes very, very complicated to get the messages through. So I was delighted to see the prospectus, and I think when I first saw it, I got straight in touch with Peter to congratulate him on the work that had been done. And I see that as the vehicle for us to be able to really articulate what our offer is to our patients, to our citizens. So for me, that's the kind of the three cornerstones in terms of the strategy for York, the strategy for the wider ICB, and how the partnership delivers through the partnership meetings. So I hope we start to see that coming through in future meetings. And it does talk as well about some further review work that I will be doing and leading over the coming months. And at the previous meeting and this month's meeting, we talked about the cost of living crisis as well. And we've already mentioned the population health hub. Again, this is a great asset for York. I see my role to ensure that all partners are not only using it to increase visibility of our most vulnerable, but actually using it to make decisions, convening to make decisions about how we best use our resources, again, as a partnership to deliver the Health and Wellbeing Board strategy. Just, I suppose, a brief highlight from this week's meeting as well. just starting to set out now that roadmap. The partnership has undergone, I think, a fair bit of change over the last few months as the new NHS legislation kicked in 2022. So there is something about what do we want to set out to achieve, what are we there to achieve, and constantly be looking to ourselves, learning and moving forward with that committee to make sure that it's doing the absolute best it can for the city. So that's, I think, the update from me. Jamila or colleagues, would anyone like to add anything? Thank you.
No, I think that's been really comprehensive. Sarah, I've covered lots of things that way, and I'm really pleased I can see real traction at the York Place Board, and lots of decisions between health and social care being made together with and some of those outside of the Place Board between Sarah and I. It's proven quite positive.
Thank you, Sarah, and thank you, Jamila. Any questions to either of them? Yes, Andrew?
Thank you. I think my questions are very much about how we on the ground will see the difference. When people come to us and say, I've tried to get a GP appointment, I've been told, this is the message I've got, it's 8 weeks and until I might get an online assessment. And these are very real issues. I'm sure that behind the scenes, the rewiring of the NHS is consuming a lot of time. But I think we need to understand, when you mentioned the winter plan, what that actually delivers, because I think we all want to see those silos being broken down and better working is in saying, demonstrating that by these interventions you've managed to deliver X, Y, Z. And that means that people are getting out of hospital faster, they're in the place that they want to be sooner, they're getting that, and I think it's that tangible outcome that we would very much like to be able to see, because I think there's at the moment not much hope. It's very dark across the country, and therefore anything that we can see is demonstrating that collective will to make things better. Please let us know that.
Sarah, would you like to respond? Janet after.
I'll give it a go. Thank you, Councillor Waller. So I think there's a number of elements to this, isn't there? We absolutely have to track for improvement. If we're not measuring it, we're not managing it. So I think that is absolutely something that is a priority. And we've had a number of conversations in meetings this week. I think Councillor Runciman, we touched on it earlier, didn't we? You've alluded to it already around data and the importance of being able to track in real time the way that patients and citizens are able to access our services or not, as the case may be. So I do think that's a real priority. I think within York, even just increasing the visibility of the pressures on general practice is leading to more helpful debate and discussions, because believe it or not, that was fairly invisible actually to the system. We're very good at reporting on and recording hospital data, far less able to do that around general practice. So in York, we actually saw this week a report around general practice and the pressures and the demands, to start to look at how as a partnership we can support that. I think the other elements are around the after effects of the pandemic, and we see these waves of unmet need due to the inability to support in terms of prevention and proactive care and screening, all of those services that stopped during COVID, and what that does in terms of rising demand. And we missed so many opportunities to be able to prevent or slow the progression of long-term conditions as a result during that time when services were paused, essentially. So we are dealing with the inevitable rising demand, and primary care in terms of capacity and number of appointments has has risen. And I wish I had the figure for you, and I'll certainly find it out what that figure looks like in York. But we have increased quite substantially the number of appointments available month on month, year on year since the pandemic. So I will find those figures out, and we do have additional funds coming our way to do the same again in terms of increasing the number of general practice appointments available. Moving away from the focus around urgent response and actually getting back to focusing on prevention and proactive care, which is what general practice is founded on. It's not there as an urgent response service, it's there to provide good primary care in terms of prevention and long-term condition management. So it is absolutely a focus, I think, but again, in the face of the unprecedented workforce constraints, we have to be creative about how we do that. We have to pull in and use all of the available resources across our sectors. So the partnership, I think, in what will we see that is different? The partnership is about convening those partners who can support, who can help each other. And the difference should be seen on the ground in terms of care feeling more integrated, population health improving from where it was a year ago, 2 years ago, given the changes that we have seen and the demands that have been placed on us, but also the gaps between the poorest and those with the best health. And again, getting much better at targeting, understanding, knowing our populations and targeting the resources, given the constraints that I've described, making sure that we're pushing them to the areas of greatest benefit. Thank you.
Thank you. Janet. It's a slight sort of reconfiguration, perhaps, of Councillor Waller's issue. I'm going to probably bring it up again when we look at our strategic plans. This health board is terribly good at high strategy. We really are absolutely wonderful. I take my hat off. The chair has led us with high strategy. What we are very bad at is actually getting anything done. Partly, as everybody says, we're not a doing partnership, but we ought to have people sitting around the table who do things. Now, are you going to be just another wonderful, beautiful, we all love strategies. I'm a great fan of strategies. Can't get anywhere without a strategy. But until you put some points in place to say how you're actually going to do it, and you talk about GP appointments, you can configure the service as much as you like, but while we've got a national shortage of GPs, it's going to be very difficult. If we were on our own, my language would be more colourful. I am rather conscious that we have got a listening audience who might be bothered, so I will restrain myself. But I am very interested to know what steps we are putting in place to actually put at least some of the stepping stones to reach our excellent, wonderful strategic targets.
Alison, do you want to respond?
I'll just step in just about some of the stuff that we're doing, because there are lots of plans and activities happening, and Jamila you'll know more because some funded for BCF, aren't they? So under the now the urgent and emergency plan, there are a lot of new ways of working, and I'm taking heart from the fact that I bang on all the time about the voluntary sector can help and we can do stuff, and we are now given the opportunity to do that. So we are seeing already people being discharged from the hospital into the care of the voluntary sector because of the new ways of working. So this is not going to happen overnight. You know, this is transformation, and we know the crisis is here, but I think drip, bit by bit is what we can do, but we can make a difference. So there are lots and lots of things happening, but not necessarily, things don't happen around a table, do they? They happen outside of the meetings, and Jamila can probably come in more about all the work she's been doing on that.
Thank you. So yeah, I agree, Councillor Lucas. So we have had things in the past, but we've had a lovely shiny documents that have stayed on a shelf, and we haven't had much traction on them. However, I think and there's a document that's coming in any other business around better care funds, and I think where in the past where we've had some decisions where health have gone in a dark corner and just spent some money and told us about it, or we've gone in a dark corner and spent money from a local authority and just told health about it. The Better Care Fund is much different now, with loads of partners there, voluntary and community sector now, commitment there, where we've seen these are the schemes that are going to make a real difference, and how can we plan using that money better. So we way back in November, we did a home first approach to hospital, because I think we got to a point where, you know, from a local authority point of view, we're thinking placing people in residential, short-term residential nursing care was not actually serving our population in the right way. We were creating dependency. So we did a home first week. From that, we've been able to say, well, what are the gaps in community and voluntary sector? What are the gaps in the domiciliary care sector that we need to then commission? We have done that. And when I've just looked at the data that we've seen, and we've started this home first approach, and to be fair, health colleagues have had to sort of test that theory, because it's very easy to put people in beds and getting the delayed discharges down. It takes a bit longer to send somebody home and keep them home. We've seen a 53% increase in the number of people going home this time last year. We only had around 25 people who went home last year. At this time, they all went into a bed. So you can see the shift then in the policies and the strategies we've got. So we're not actually waiting for strategies to be completed. A bit like the dementia strategy, we're starting before, and then have those clear action plans at the back of those to say, you can, Health and Wellbeing Board can hold us to account on that action plan at the back.
Thank you.
Thank you very much. I'm very happy to hold people to account. But what we probably need are, I think that the waiting is the action report, so that we get an ability to monitor through Health and Wellbeing Board things we've agreed and get an update on how it's going. That will be a welcome way forward.
Thank you. I'm going to ask Sarah also, when she comes back to us next time, whenever that is, and I think it might be 6 monthly. One of the things that is bothering me at the moment is capital. You've got some buildings that are getting very old that have got GP surgeries in them. Bishop Thorpe and Weldrake spring to mind. And that, with the lack of GPs themselves, is obviously putting pressure on people in the area and pressure on the system. And I really would like to know a bit more about the capital funding that can go in to improve, particularly those two surgeries, or any other that you, Stockton on the Forest was the other one, that you are looking at, because they tend to be in villages where bus services are a bit intermittent. And we don't want somebody not to be able to get the help that they need because they can't get to the surgery. So I'd be very grateful if you take that up and bring it back next time, Sarah.
Yeah, thank you.
And Denise, and then we'll finish.
Okay, just following this question, just following on from the other questions in a way, and that comment about capital funding as well. I was just thinking similarly that you know, partnership working has taken great strides forward, and we've got a lot of stuff that says what we want to do, and which is good as well as part of that strategy level. And you keep referring to available resources, and we know that that's a big problem. How can you use your position in this new architecture to help us know when budget issues, when new budget issues might be coming on the agenda, or when we have even more, there are challenges that we need to address together, or opportunities even.
Thank you very much.
Trying to frame
that's a good question. Well, and I think it's a question that I've probably been asking myself as well. I mean, I would see that at the heart of my role in terms of again, as a partnership. If we are to have as a committee, if we are to have autonomy around decision making on behalf of the Integrated Care Board, NHS bodies, on behalf of other partners that come around that table with their own delegated limits for decision making, then we do have to build confidence in each other. We have to do that, really understand the resources that we have as a partnership at our disposal. So what are the resources, the totality of the resources to support children and young people, families, people of working age, older adults, people living with frailty at the end of life. So across the whole life course, what are our collective resources across adult social care, children's services, communities teams, so the local area coordination networks, as well as the health services across that whole life course. And then within that, just starting to understand what the totality of that is in terms of staffing, buildings, equipment, because that's what our resources are paying for. That's what the money is there to pay for. It's tied up with those elements. So I think I see my role that in terms of convening that partnership being very much about starting to unpack that and really understand how do we utilise those collective resources differently, because we have to do something radically different. Otherwise, we are just going to see the same results. I'm very clear about that. And the legislation has helped us. The health legislation that came in last year will help us to remove those barriers. So we have to take that forward and do the very best we can with it from an integration perspective. So having autonomy as a committee to make those decisions starts from a basis of understanding what the resources are, trusting in each other, understanding where the key risks are, the pressures are, as you said, so that we can start to take those decisions.
And then we're going to move on to the next one.
Thank you. I was just going to add that Councillor Cragen, I think in health, I think there's probably, and we see it time and time again, that there's enough money in the health system. It's about how we utilise it and move it across organisations working across health and the local authority. We know quite a lot of the issues that we have in health are because of the wider determinants of health around employment, housing, places, and more around the local authority and how we can work with health colleagues to say, well, is the money and the resources in the right place, or do we need to move more down into communities? And I think that's the work, some of the work that Sarah and I, and conversations Sarah and I are starting having now about where can we best use the resource that we can, rather than saying we don't have enough money. I think it is there, it's just probably in the wrong place.
Thank you, Jamila. Right, we'll hello, Lisa. Good to see you. That's fine. That's an interesting discussion, Sarah. You can see why we need you here. So all I need to check, we've noted the report. When would you like a report back from Sarah? Is 6 months all right? We don't need it at every meeting, do we? No, I'm getting lots of shakes of the head. 6 months, there would have been an election between now and then, Sarah. So personnel may change or may not. Right, we're on agenda item 5 on page 45. Having just done 6, Lisa, just for your information, we're working slightly awry today. And Peter, you're presumably going to present it. Can you put the mic right in front of you?
Certainly, thank you, Chair, and
Thank you.
Evening, everybody. It's quite a short paper, so I'll try to be quite brief. It does link to previous discussions. We have a new strategy, a new document, a health and wellbeing strategy for the city, which is 10 years, starting in 2022. And we want to, we must move on to the action planning and getting some very clear ways in which we're going to put it in practice, and how we're going to measure it so we know it's having an impact and making a difference. And that's what this paper is about. The paper sets out the ways that we want to do that, and from the March board meeting, that will be the first time that the board receives the action plan and what we're calling the population health outcomes monitor, the thing that we use to determine whether we're making a difference. And what we wanted to do with this paper is just to make sure that the board are happy with the approach. So this is about the approach at this stage, and in March we will have the actual thing itself. And what we're proposing are two things: an action plan, and what we've put in Annex 1 is a suggestion of the way we lay out the action plan. And in the strategy, we had 10 population health goals. We started with the principle that the key thing we want to do is reduce that gap in healthy life expectancy, so that the poorest in our city don't have that huge gap between their health outcomes and those that are more affluent. That was our overarching goal, and as part of that, 9 other goals, which were based on the evidence of what public health intelligence will tell us leads to early death and disability, but also based on all the engagement and the work we did with the board to set them. 9 other goals that focus on things like isolation, things like diagnosis of disease, things like mental health of our children and young people, that focus on smoking. Those 9 goals are really clear. We set really clear targets. For instance, we want to reduce the number of people who are drinking over the recommended amount of alcohol from 20% to 15%. So they're very clear. We want to make sure the actions flow out of those clear goals. But then we did also set 6 ambitions, which were much more about the system. So an ambition like, let's become a health generating city. Let's start the things we do earlier in the cycle with children and younger people more often. It's harder to produce actions from those things, but we don't want to lose them because they're important ambitions that we set. So what Annex A shows is that we'll set some actions around the 10 goals, but for each action we'll assess how it helps us meet the ambitions. Just a really practical example, under the smoking one, we all set an action that is very tangible. And actually, we've already started on this, but by 2024, we've got a commitment that everybody who's an inpatient or goes through a maternity pathway at the hospital is identified as either being a smoker or not being a smoker, and is offered within 24 hours of an admission a treatment at bedside using the medication that is on offer and the behavioural intervention, and then is discharged into community stop smoking services. That's something that we are starting the very beginnings of, and actually started at York Hospital back in September. And as we go across the next 2 years, it's going to be, I'm pretty sure one of the actions we put in here to make sure that happens, and happens to its fullest extent. Something really tangible there. And we hope by March you will have a nice list. We think of 2 to 3 actions per goal. We think that's manageable. We think if we set ourselves 100, we probably fail. But if we set ourselves 2 per goal, that's about right. It will last over the 2 years, because 10 years was a very long-term strategy. If we take it in manageable chunks again, we think that's a reasonable thing to do. And then the population health outcomes monitor, that's Annex 2, or sorry, Annex B to the report, is measuring what's happening at a population level, the data that we've referred to already today. So takes us through each of those goals again with some fairly standard public health indicators that we can gather very regularly, that we're very used to dealing with. We know what they're telling us. They won't go out of date, and they're very robust, so we know how to interpret them. And so we worked hard with some colleagues to make sure that those are the right indicators. So what we're really asking the board to do is to comment and to note the approach, and certainly between now and March we can go away and refine any of the actions, any of the indicators that people would like us to change. We can have a rethink, but the intention after today's meeting is Tracy and I have a piece of work to do to go around partners to make sure the action plan is nicely filled out, and by the time we come to March there will be some important actions there for us to sign off. Thank you, Chair.
Thank you, Peter. We have been asked to comment on Annex A and Annex B, and we have to approve the 2 documents, but we need to go back to page 47, where there are some options, 5 to look at, and I'd like anybody to comment on any of those particular 5. Thank you, Sharon.
So, thank you, Chair. I suppose I wanted to give a little bit more context to some of the indicators which might be helpful. So our health and wellbeing strategy recognises the importance of what we call the wider determinants. So if we think about employment, housing, work, social connectedness, all of those things we know impact on health. And so at face value, some of these indicators may appear not to measure those things, but actually they will. Because if, for example, we look at the indicator around reducing sedentary behaviour, so that 4 in every 5 adults in York are physically active, there's a big element in there that is around the environment, about planning. So if we think about a lot of the work that the council does, increasingly with partners around new housing developments, York Central, for example, we can start to, as a health and wellbeing board, start to engage with and influence some of those policies, so that we actually are creating an environment that makes it actually the easiest option is to walk or cycle. So when we look at most of these indicators, when we are looking at the action plan and the deliverables, there will be a range of actions that we'll be wanting to focus on. And then the framework that Peter's presented to us are the suggested indicators that will allow us to measure over time, over the 10 years of the strategy, whether we're actually delivering on those things, whether we're actually achieving the difference that we want to make. So I just wanted to say something about the wider context and how this can be used.
Thank you, Sharon. That's very helpful. Andrew?
Thank you, Chair. I'll neatly segue into that comment. I've had a number of discussions with Sharon over the years in terms of access to recreation space in the city. It is an issue which I feel very strongly about, with my part of the city losing out considerably, and therefore access to good play areas, to kickabout areas, to have that space and public rights of way, so that people who acquired during lockdown the ability to see their local environment and appreciate it. And that was one of the silver linings to a very difficult time for the country. But I think that needs to be factored in, and planning is an important feature of ensuring that there is an environment where walking and cycling are the easiest option and the preferable option. But I think that that does need to be factored in, so that all children in the city benefit from that. I think with the indicators, I'm always conscious of the statistics that come out, and fingers are pointed at certain parts of the city that the life expectancy is lower, the healthy life span is less, and therefore I think my question back to you is how is this living the reality of the problems that people are facing on the ground, and how will this make life better for them so that they do have those longer, healthier lives?
You're absolutely right, Councillor Waller. What we've got here is a high level kind of performance management framework for the whole of the strategy over a period of time. But certainly Peter, through the Population Hub, will be very aware that we're doing a great deal of work looking at what's happening within York. Certainly looking at the intelligence we've got and the data we've got, particularly looking at where we've got those pockets of significant inequalities, but also where we have other indicators. Some of the outer areas of the city may not have significant deprivation indicators, but they may still have difficulties in being able to access services. So it's looking at the health equity as well as looking at health inequalities. I don't know, Peter, if you want to say anything about the neighbourhood work that we're doing.
Well, yeah, just a couple of things to pick up Councillor Waller's point. I've just Googled. We can get access to green space data at quite a low level, Councillor Waller. So we can look to put that into the physical activity indicators of this. I think that would be a really helpful addition, just as to pick up the point. I think the wider point about what we're trying to do with the actions is that I think there's probably two things that this strategy needs to try to do as we take it forward. There are some actions that as a board we want to set, but there is the way the strategy fits in with wider strategies across the city, and this was developed in line with the climate change strategy and the economic strategy, and hopefully acts as a rallying cry and a sort of a why we're doing what we're doing for lots of other pieces of work that as a board we probably won't have the ability to necessarily control, but we hope that the aspirations and the strategy set. I say that because I think that we've tried to strike a balance in both the way we're measuring what we're doing, that the outcomes bit, and the action plan in having things that are manageable and achievable and that are within the remit of some of the organisations represented around the table, and then noting that lots of other bits of the puzzle are going to have to happen. For instance, the work that is done across the city on housing stock and access to housing and affordable housing. All the levers aren't in the Health and Wellbeing Board's sort of gift to pull there, but setting aspirations about everybody having a healthy standard of housing, and housing as a health determinant, I think are. So that's what we try to do in the strategy, is to that balancing line between what we feel we can do and the actions that will roll out of the strategy, and also setting up the aspirations of a healthy building blocks for health model, which is what we do. So we can certainly take lots of comments, and happy to do so via email, on specific actions that people would like to see in here, and ways that we're measuring that we haven't included so far that we could incorporate and make sure the data is right for this.
Alison?
Yeah, so I was just going to ask about the indicator for the suicide rate and self-harm rate, which is on page 52. So I'm assuming the indicator is about completed suicides rather than attempted. And if that is the case, can we have an indicator for attempted? Because it doesn't really show the true picture, does it, if it's just complete, which might give you a headache, Peter, but I don't know if that's possible. And the same with the self-harm, which you're proposing to measure through hospital stays. Again, that's missing out GP attendances or A&E attendances. And I know it's difficult to measure. Well, it's not difficult. We are not measuring self-harm adequately. I know that from, what I've been told. So we need to sort of look at how we do that properly to sort of really give us a picture. So is that possible to go a little bit further, so it's not just completed and hospital stay?
Yeah, I always try to be as helpful as I can, but also not raise the expectations, because I guess the reason that a couple of these indicators are the way they are is for instance, with the suicide rate, suicide is a coronial verdict. And in that sense, is quite a robust. It either is or isn't. And in accordance with what the coroner said, the attempt is not captured in the way that would enable us to do it in this way. I think we can find ways through deeper work that links into the strategy to reflect both those things. I would probably say the work that public health are leading on suicide prevention, the work we do to audit completed suicides, but also to work with our police partners, particularly around the suicide city and reducing suicides in the city work, very much looks at much deeper level data than what's reflected here. The worry would be if we tried to make indicators locally that weren't the ones that are used by the ONS and national sort of bodies, we might fall foul of it telling us something it's not. I think that the female and male rates for suicide are really important, because you're absolutely right that males are more likely to complete suicide successfully. That doesn't mean they are attempting more often. So I think there's probably something there about a narrative about when we put this into the public domain through these papers, making sure we write that in the narrative very clearly, so it's clear what the data is and isn't saying.
Yes, Lisa.
Thank you, Chair. And I suppose it's just to build upon that. We obviously receive a significant number of calls for service in terms of concern for safety, somebody in distress, etc., which technically could be an attempt suicide, but it wouldn't be recorded as such. So if we get called to an incident where somebody's in significant mental health crisis, and the assumption might be, or it might indicate attempt suicide, it wouldn't be recorded as that. It would be recorded as a concern for safety, or somebody in mental health crisis who might be referred through to mental health services. I can't comment on how the mental health service would then record that person's circumstances, but it certainly wouldn't be recorded as such, regardless of the circumstances that we get called to.
Thank you. David, do you want to comment?
Short answer is no. Sorry. We record all reasons why someone is referred or uses the service, and we can pull that data, but it's I don't know how it would link to the data, the general data that Peter talks about.
Well, I think we could take this out, so the meeting probably, Chair, to look at with David how that data feeds through, and I would probably be asking my colleague Lisa suicide prevention with the public health, because I'm pretty sure some of those conversations have been had in terms of the data. So we could take that out and bring that back next time as an answer.
Janet, and then I'm going to move on to the next item.
Yes, I mean, I was just going to, in a sense, what I was following up on, looking at the options, was your question at number 4, which I think is supremely at the heart. How do we ensure ownership of the actions in the plan by all the different partnership organisations? Because it isn't something that any one of us can do all by ourselves, which is why we have a health and wellbeing board. It's got to be something that everybody not just says, oh yes, that looks good, but commits to, as David has said, trying to tackle perhaps some of the tricky bits where perhaps not all your statistics that you gather fit. And so what are we going to do about making sure that everybody is absolutely signed up to making this happen?
Thank you, Janet. I think what I want to say is, particularly with 4 and 5, I really would like people to think about them and send their comments. If you send them to Tracy will get them to the right person. 4 and 5 are quite deep. I think you could probably write an essay on each of them if you were so minded. But I do want to ask the board, when would you like to see progress against the actions? Every 3 months, every 6 months? 3. I'm getting an indication.
Start with 3, and let's see, while it's gathering pace, I guess let's do it more often.
Yeah, fine. So 3 months, and then comments particularly on 4 and 5 of the options. Any other comments you wish to send to Tracy, I'm sure she'd be very pleased to have them. And are we okay to approve the 2 documents that Peter has presented? Nobody's saying no, Peter, which obviously indicates assent. Right, now we go on to agenda item 7. And it's on page 79. And is it Sarah or is it Peter?
I think it might be me again, I'm afraid. Thank you, Chair. And I may invite Peter to jump in as well and just give his comments. So what you have in your pack is the Humber and North Yorkshire integrated health and care strategy. So just a bit of background, and I suppose with a caveat to say I attended my first integrated care partnership meeting as well today, just prior to this meeting. So I think it's probably fair to say I am also just starting to see how the pieces fit together. But I think I mean, in terms of the strategy that you have in the paper, so it's an appendix to the document. Actually, reasonably, I think, refreshingly simple would be my sort of conclusion from the strategy itself. And I think that reflects for this this ICS, for Humber and North Yorkshire, new organisation, I think was fairly keen to keep this as simple and as aligned as possible to the work that is already going on across the 6 places of Humber and North Yorkshire. And the strategy is something that every new integrated care system created in July 22 had to produce. It was something that was a requirement. And in terms of the overall sort of framework that this sits within across sort of collaborations across health and social care across England, there's sort of 4 pieces, I think, to the puzzle and where this strategy sits into that. So the kind of founding stone is the JSNA, so the Joint Strategic Needs Assessments developed by the local authorities, and the Health and Wellbeing Board strategy. So that is an absolute cornerstone of all of the strategies that have been developed across England. And the Humber and North Yorkshire strategy is no different. There was an awful lot of work done, I think, starting very swiftly when the organisation was established, to very much base and found the strategy in those 6 Joint Strategic Needs Assessments and Health and Wellbeing Board strategies. And the Integrated Care Partnership strategy is very distinct from the NHS function of the Integrated Care Board. It's the sort of sister board, if you like, to the NHS Commissioner function, in that it is genuinely that collaboration between local authority, NHS, and many wider partners and communities served by the geography of Humber and North Yorkshire. And then there are 2 other bits of the architecture that the strategy needs to be mindful of. One is, or 2 really, are around, again, the NHS's response to that strategy. And it's useful for the Health and Wellbeing Board members to be aware of that. So there is a requirement also to produce a 1-year operational plan for the NHS, and also a 5-year plan for the NHS. And that must have regard to this strategy. So that's the importance of it. That's where it sits within the context of the new architecture. So I just wanted to sort of outline that. And then I'm going to go to the paper and sort of just cover some of the items set out in pages 3, 4 and 5. So first of all, in terms of the approach, that it was very much developed from an ongoing dialogue with communities, very open, lots of open engagement sessions, open invite sessions. Hopefully some of the members of this board would have been invited to those, and they took place over the summer into the autumn last year. In terms of the themes, it's again much broader than health, much more about the wider determinants of health. It's very much not an NHS strategy, much more around the broader social and economic development aspects, many of which we've been talking about in terms of open spaces, good jobs, good education. And there's a number of themes running through it. Think person. So people are whole people. They're not services or conditions or diseases. They are people. So think person is one of the key elements of the strategy. Secondly, around think family. So thinking about those generational aspects for the people that we serve. So young children, the impact of family dynamics on those children, the ability to be able to access school with food in their bellies, a warm home, etc. So think family is another really key theme to that, and also the carers that are supporting members, both in terms of informal carers, friendship networks, that are wrapped around people. And then the third element around think community, much more around, you'll probably know, traditional NHS tends to look at illnesses more than it looks at the assets that people bring, a very deficit model. We sometimes refer to that in the NHS. We look at what's wrong with people rather than what's right with people. So the strategy, and I think that's because it's born out of that collaboration with local authority, NHS and wider partners, is very much founded in the assets of communities and the assets that people bring. And we've talked about the life course approach earlier that we've adopted in York, and that is again another key theme through here in terms of cradle to grave. What are we doing collectively as an integrated care system to support people to start well, to live well, to age well, and to die well. And at every stage, I think, in terms of delivery then of this strategy, it's very much back to action in terms of, well, okay, well, if we're going to do that, it's understanding at the granular level about each of those partners' roles in order to prevent those diagnoses or conditions from ever emerging, and when they do emerge, absolutely make sure that we're focused around reducing the progression of long-term conditions and taking every opportunity rather than working as silos, sectors, services, that we work together as partners. Easier to say, very, very tricky to do, and I think I said earlier, if we're going to get radically different results, then we have to work radically differently, and that is the point. And it's been more difficult to do that perhaps in the past, and we have a real opportunity to do that now with the purpose of the integrated care partnership being about that duty to collaborate. We have a duty, both as statutory providers and our community providers, to work together for the people we serve. So that's a little bit about the strategy. I didn't want to go into too much detail other than to say and make that point that it is about how we deliver. And I would like to congratulate, I think, Peter, Councillor Runciman, and others who have been involved in this from a York perspective, because having read the strategy, and I was involved in the strategy, I should say, but more from in my previous roles, and I was a director working across Humber and North Yorkshire prior to joining the York system, and having read the health and wellbeing strategy for York and the prospectus, I see an awful lot of York in here. It really does feel like it comes through very, very strongly, and the work around and the focus around building blocks for health creation, the focus on children, and that life course approach, as I said, comes through very, very strongly. And I think that is well in part to the focus that you've had as a place. So that's reflected well. And I do think actually there are probably some areas that I see that are maybe less strong, but also very, very relevant. That I think the strategy helps to point us to in terms of supporting homeless and some of our most disadvantaged people in society who've experienced those severe multiple traumas that points us to, the role of carers, the role that academia and businesses bring. I think that's very evident in the integrated care partnership strategy, buying local, and what every organisation can do that we commission, the role that they play in terms of being that local employer, attracting local people, supporting people with local skills developments back into work. So they are some of the other elements that I think actually that's really helpful for us as a system to think about how we deliver as well. And moving forward, how would I see us working with that? I would see the ICP as our opportunity to celebrate our achievements. So working with colleagues, the great thing about being part of something bigger is to be able to celebrate some of our successes, share that with others, share that with partners, but also hear from others, hear about the really good work that's going on elsewhere in terms of our other places in those pockets, and bring that back to York, bring that learning through, and put our provider partners in touch with each other as well. So that's a bit of a whistle stop, and probably didn't focus quite as much on the content, more about how I would see it connecting with the work that we are delivering. And yeah, D word, focusing on delivery, action. results.
Thank you, Sarah.
I don't know if Peter or Councillor Runciman would like to add anything, given your involvement.
Peter, do you want to say anything at this point?
Sarah stole my one point, which was we got our health and wellbeing strategy written in time to be reflected in this, and I really think it is. I think inevitably we are one of 6 places in this big new structure now, and there are some aspects of this, for instance, the coastal inequalities, which don't sort of affect us. So I guess that the challenge is, how do we make sure York's needs are not overlooked, and that assumptions about York within this region are actually sometimes challenged. I think some of the things we've heard earlier on around poverty in the system sometimes belie some easy assumptions about us as a city within a system like this. So I think that's a challenge for us, but I think having our health and wellbeing strategy in time to be reflected in this has been a good start.
To make a comment before I bring in Jamila, I found it a very, very interesting report, although I didn't think it was particularly short, I have to say. And I like the place pages in particular, because they bring out the differences between the various areas. And before I bring in Jamila, what are you going to do with it? Where's it going? Apart, I mean, I realise it will go up to the DPH or whatever, the DH. Where's it going? Are you going to circulate it? Will it be on the web for people to read? What's the plan?
Yeah, thank you. So I suppose with my ICB hat on, my understanding, and I might have to check with Peter because I may have missed the last meeting. My understanding is that it will be in the public domain, so it will be published on the website. And I know at one point we were talking about this being, you see the reference to this being a living, breathing strategy. And I think what that was really getting at was actually, rather than this being a document, a PDF document that sits on a website, that actually this would be a live document that had different sections on a website that would be constantly updated. So as things change, as policy changed, or as a particular emerging pressure comes through, that we would be able to update the strategy. So it wouldn't be a document, it would be a strategy, web-based, but then at any point in time it was downloadable. So that's my understanding from the wider ICS perspective. In terms of the delivery, I think that will there's a number of elements. So I think across the ICS architecture there are a number of committees, and some elements can and should be tackled once. As Humber and North Yorkshire, there are some things that can be done once together, which makes sense. However, the vast majority of action is within place. So for me, it's more about again that triangle that seems to sit in my head around the health and wellbeing board strategy for York. Because if we deliver that, we will deliver this. We will deliver our contribution to the integrated care partnership. So it's one of the same for me. And again, given that we have so many commitments and so many priorities, we can't have another set of priorities over here. It has to be aligned. It has to be the same priorities. So much of what Peter's just been talking through in his previous item, and much of the work that I will be doing as a place around the urgent emergency care plans that we've been talking about, I want to ensure that everything is aligned as much as it is possible. So if we deliver that for York, then we deliver our contribution to the integrated care partnership.
I've got 2 speakers. I've got Jamila and then Martin.
Thank you, Chair. I think some of the strategy reads like a health and wellbeing board strategy, doesn't it, really, which is a positive thing. I think my point was made by Peter, really. I think the strategy is very wide range, it's really quite high level, and it talks, and it is a very Humber and North Yorkshire feel to it. And it's about how do we ensure that York Place doesn't get lost in the inequalities around the coastal. I absolutely 100% agree that there are wide-ranging inequalities in our coastal areas. But if you look at our data that's collected through the population hub, there's inequalities within York that we really need to focus on. And the strategy doesn't actually bring that out. It talks a lot about coastal areas. And I do think we probably want to look at, once the strategy is published, and I do like action plans and things at the back of strategies to say, well, okay, how does this strategy then aligned to some of the work that we're doing around urgent and emergency care, Sarah, and the delivery of those wider determinants with the Health and Wellbeing Board. I'd like to see something back here to say, well, what's the York Place offer of the strategy?
Martin?
Thank you. Likewise, I think it's very good strategy. I think likewise, Sarah, that there's perhaps bits that I don't see York coming across as strongly as it could do. However, what I would say is I really welcome the think person, think family, and think community, and actually the concept of organising that in a way that just doesn't talk about community as being something that is just a thing we don't understand. But actually, you talk about think family and their network. What we'll see over the next 2 weeks, and probably next week, is the government launch their response to the National Care Review and the National Review into the deaths of Arthur and Star. And one thing that will come across very strongly in that review will be how networks that sit alongside families, that sit within a community, will really protect and keep children safe. So it's not just a community, a whole community, it's much more about their aunts, uncles, friends, the people that they have on Facebook, and the people that they will meet and talk to in the pub, or wherever they may go. That's probably the wrong analogy for the Health and Wellbeing Board. But I think I really welcome the sense of, I think it's consistent with what's happening nationally for children. And actually, we will probably mirror some of this for the Children and Young People's Plan that we're in the process of developing.
Good, thank you, Martin, for that. I think that's probably that for that item. Oh, Andrew, yes?
I think, thank you, Chair. Just picking up on the points that Jamela and Martin had raised. I think challenging the outward perspective of York. There is a York outside of the city walls, the tourist area, and those are very real challenges that communities face. And therefore, I think it's about demonstrating this is keeping it real. And this is something that we can take to all of our communities and say, it's been identified and this is what's happening. People are worried about the length of time it takes to get an ambulance. There has been significant impacts as a consequence of COVID in behavioural patterns in many parts of the city. And there's a huge amount of work going into targeted work on bringing that situation around. But I think the concept of community resilience is vital. And in your report, you talk about if Yorkshire and Humber were 1,000 people, what would they be? My view is, if Yorkshire and Humber was still part of Scandinavia, what would we be doing? And the examples of what's going on in Denmark, in Finland, there are some very strong examples of this is where the society can go, and the Americanization of some of the aspects of public services really does chill me to the bone. I think there is a direction of travel that we as a board and with partners have to challenge. Thank you.
I won't ask you, Sarah, to comment on if we were Scandinavia, because I know one of the things we do would be paying more taxes. The value of public services is well, it's undervalued. There you go. Right. Thank you for bringing that, and it will come back to us. I think now it's Sharon talking about progress on recruitment for Chair of Mental Health Partnership.
Yes, so for colleagues who may not be aware, one of the subgroups of the of this board is the Mental Health Partnership. It's an innovative partnership which has spearheaded a number of developments, some of which have received national recognition in York. The previous chair of the Mental Health Partnership, who many of you know is Tim Madgwick, has stood down as chair of the Mental Health Partnership. And so we are seeking to appoint a new chair, which the partnership has agreed, and we agreed previously as a Health and Wellbeing Board, would be an independent chair. So somebody that is not employed by any of the organisations that actually attend the partnership. We did go out to advert and unfortunately had no applicants. So Tracy and I have been working with a number of volunteers from the membership of the Mental Health Partnership to look at developing a different way of advertising this opportunity. So that work has been pulled together. We are reviewing the draft of that. It will go to members of the Mental Health Partnership for approval. And then our intention is to go out to advert again by the end of this month. Seek then to go through the selection process through February, so that the new chair will be in position, hopefully, for the next partnership meeting, which will be in March. We won't be using a traditional approach. So rather than recruiting this as a post, the idea is that we will use social media, we'll use existing networks, perhaps targeting specific individuals that we think would be suitable for the role of chair, and really also offering the opportunity for any interested candidates to meet members of the partnership, so that it's a more informal, inclusive process than the one that we used previously. So hope by the time we come to the next meeting to be able to announce who is the new chair of the partnership. So happy to take any questions, Chair.
I think what I could say, Sharon, is thank you to you and Tracy for the work that you've done. But if anybody has some bright ideas, if you know of anyone who might be interested from the voluntary sector or from the statutory sector for that matter, please email Tracy and she will pass them on to Sharon. Don't send them if you think the person is so frantically busy that they wouldn't possibly have time to do it, because I do know the amount of time that Tim put into it was considerable. You might not need to put quite that amount of time into it, but certainly it will take time, and any suggestions are welcome. Are there any questions to Sharon? No, thank you, Sharon. So we go on to our last item, which is an urgent item. It is the Adult Social Care Discharge Funds. It had to go in by, I think, the 14th of December, and we have to ratify it. We couldn't wait till the meeting, but we have to ratify it. Now, you should have an extra bit of paper that says agenda supplement, I hope. And if not, you'll just have to listen to Jamila introducing it. Righto, Jamila.
Thank you, Chair. Yes, we did have, as some of you may know, earlier in 2022, the government announced £500 million money going into adult social care discharge fund. This initially it was highlighted to come straight to local authorities to help with the discharges from hospital. There was some delay and toing and froing in the allocation of money, and then when the allocation did come down, it changed from the 100% to local authorities to 40% directly to local authorities and 60% to the ICS. So that was a bit of a change in the way money was allocated. But I'm pleased to say within York and the direction nationally was that they should flow through the Better Care Delivery Group. So we had a much more of an integrated approach of using the money. So despite that split, we didn't feel that the monies were being used in two separate ways, but much more in an integrated way. So the Better Care Delivery Group does have all partners around the table, including mental health, community voluntary sector, our acute health colleagues and our ICS. So we did have plans for the use of the money. As you can see there, the ICS were allocated just over 1 million and the City of York Council 609,000. There's various schemes within the report. I'm not going to go through all those schemes, but I can say those schemes will be evaluated regularly. Majority of the schemes, as you can see at the back, have been implemented now. And majority of those are around discharge. You can see within the report that if you look at the schemes, they're all focused on discharges from hospital, and that's because the guidance that came through was really quite tight on. We could only use the monies around discharges and supporting discharges from the acute hospital, which is the right thing to do because we want to make sure that patients can receive the right acute care at the right time and support those discharges out. We followed the home first approach here, so we tended to move away from spot purchase beds into additional community voluntary support around transport, pop-in visits, increasing domiciliary care, and then support to the mental health trust around delays within the mental health hospital, and including A&E. So that's just a quick tour around the port. I do usually bring a 3-monthly update on the BCF, which I will do. But I must add that we had, since this report, an additional 200 million announcement from the national government. And we've had allocations to York, which have resulted in monies being spent on step-down bed provision as well as others. This is not included in this report, but will be in the next report. Those 200 million do not need to be ratified here at the Health and Wellbeing Board. It's just the use of this discharge fund. Thank you, Chair.
Thank you, Jamila. It was very interesting seeing discharge from the inside, which I did. I saw the occupational therapist, I saw the physiotherapist, I obviously saw the consultant, but just to watch it happening was, in fact, it was happening to me, made it very, very interesting. It's really important that this funding is used well. The issue is not, and I'm sure everybody around this table realizes, it's not just in the hospitals. It's out in the community, it's with yourselves in the care sector, and the funding is really, really important to make sure that the hospital beds are freed up. Equally, on my favourite subject now, it's really important we do as much as we can to stop people going into hospital. And we put services in the community, we've mentioned some of them already, which can get people help early before anything gets too serious. But can I ask, has anyone got any questions for Jamila about the discharge fund?
Oh, sorry, it always takes me, I'm not good with this sort of thing. It's a discharge fund, and obviously it is hugely welcome. And the fact that you are focusing very much on discharge into people's homes. And like Councillor Runciman, I have got at the moment a very deep and very personal interest in the way this works. How long is it going to last, though? Is this just a one-off lump sum of money to last sort of perhaps while we cope with a temporary, inverted commas, crisis? Or is this part of a proper investment into adult social care?
So we've had strong indication that this money will flow through into next year. The Better Care Fund has been agreed now for another 2 years, which is really quite positive. So you don't have the normal, NHS cycle of year on year. Running it through the Better Care Fund gives you that 2-year, 3-year focus. What we want to do is make sure that the schemes that we've got in place are working so they can run over into next year. I think sometimes where you found, which we think is really quite pleasing, that people have heard us and lobbying to the government about short-term schemes do not work. They work for a short period of time and recruitment can take a while. some of the schemes we put in place are aligned to some of the recruitment, so it needs to be longer term. And Sarah and I have agreed to go on risk on some of those to say, well, if the schemes are really going to work, like what we call CRT at home, that actually double up care packages, our OT support, those kinds of support, I think Sarah and I can say, well, yes, those are proven to work, so we can roll them over into next year. But hopefully when we bring the BCF report back here, we will have those discussions about those schemes that have really worked to support discharge. At the moment, we know we have people staying between 5 and 8 days in hospital. We want to reduce that with these schemes between 1 and 5.
Because for me, the issue around care certainly into the community is that it isn't necessarily something short term. Some of it has very long term implications, that if you are going to give somebody support, you've got to have a way of saying, okay, if you still need it in 5 years' time, it'll be there. And that's my worry, is that is this going to be able to invest? Because people can't just say, oh, well, I'll get better in 2 years' time, or their health condition may need very long-term support, and we ought to be able to provide that.
Yeah.
I mean, I'm very grateful. I think this is tremendous, but we ought to be looking at the way in which we can make it core funding.
Yeah, and I think it's very welcome, because if we can discharge people earlier on, because you've heard me talk before at the Health and Wellbeing Board that people delaying in hospital, causing an additional pressure on adult social care, because their care needs are more dependent, so they will need double up cares if they've been staying in hospital 14, 15 days longer than they actually need it, or go into residential or nursing care. Through this discharge fund, if we can start discharging people earlier on, it will not only release acute beds for those people who need them, but also have a positive impact, we hope, on the social care of that least dependency option of support, rather than crisis support that we often have. But yeah, it's good that we've had indication that this fund will run into 23-24.
So one final speaker, which is Councillor Waller. Would you like to?
Thank you. Very quick question to start with. In other parts of the country, there was mention of people being discharged into hotels. Did that happen here?
It certainly did not.
Thank you. Good to hear that. I think in the review that you make, it would be very helpful to have itemized those things that you were able to do as a consequence of this, that you would want to continue to be able to do as a long-term objective. Thank you.
Thank you. Just to confirm that I did see this before it went in. Jamila keeps me informed, and I knew what we were hoping that you would sign up to. So I have to ask you, are you happy to ratify what you see? Yes. Yes, Jamila. Oh, isn't that good? Yes, what a relief. I haven't got any other urgent business. So I think that concludes the meeting. And I'd like to thank everybody for coming and for their contributions. It was good to see you all. Somebody tells me I'm not allowed to say Happy New Year, but I will wish you all the best for 2023, even though we well started it. Thank you very much. And thank you to those who are watching.
The Chinese New Year.